for the opportunity to contribute to this important discussion. So my talk will be about HIV self-testing as one of the strongest examples for self-care and practice, and what we have learned about the public health value in its role in community-led delivery and potential to sustain HIV impact in a very constrained funding environment that we're finding ourselves with HIV. Next slide, please. So just again, speaking about sort of self-care and self-testing, the critical to health systems, and I think have heard it earlier on already, to achieve universal health coverage, we must complement the traditional provider to client model that is at the heart of health systems to a self-care model. And self-care interventions are amongst the most promising and exciting approaches to improve health and well-being from a health systems perspective, and that is what I speak about, and also for the users of these interventions. So self-care interventions have the potential to increase choice and autonomy when they are accessible, acceptable, and affordable. Self-testing as self-sampling, that is the focus of my talk, have become increasingly important to fill the gaps, the diagnostic gaps for many infectious diseases. And it's not only for HIV, we've done also work on COVID-19, self-testing, viral hepatitis, very important also as an access point for diagnostics, and to provide an alternative to conventional testing services that are convenient, private, and increasing access. So self-care is often framed around autonomy, dignity, and the right for people to make decisions about their own health. But the public health case is equally strong. HIV self-care can increase engagement and autonomy, expand access and equity, improve quality of care, reduce costs for both health systems and individuals, and increase efficiency. So for HIV, it's particularly important as we are asking health systems to sustain prevention, testing, treatment, and care with very few resources now, and fewer healthcare workers and increasing demand. And self-care helps bring services closer to people while allowing formal health systems to focus their capacity where clinical care is most needed. I think this is the major argument for this. Next slide. Very quickly, speaking about the self-testing investment framework that was underlying the framework for the work that I was involved with over 9 years on the STAR project, that provided sort of the underpinning, the evidence agenda for the STAR project for HIV Self-Testing Africa project that provided the evidence for the paradigm shift in HIV testing towards HIV self-testing. It helps us also to think about HIV self-testing not only as a diagnostic tool, but also as a broader health systems interventions. So HIV testing is a gateway, not the endpoint, to prevention, treatment, and sustained HIV impact. And there are several impact pathways for HIV self-testing. A negative result can link someone to HIV prevention. Very important now with very effective HIV prevention interventions like PrEP, long-acting PrEP with lenacapavir, for example. A positive result can link somebody to confirmative testing, and that is absolutely required for HIV self-testing, and then to antiretroviral therapy access. For people living with HIV, self-testing approaches can also support disclosure, partner testing, and linkage, relinkage into care if they have moved out of the health delivery system to increase its retention. There has also other broader effects, and I will look at this as well. Cost and time saving for users and health systems, improved coverage, greater equity of access because we're increasing the access points for people to access testing services, and also reduced costs and pressure on health clinics. The key point is that HIV self-testing creates value because it simplifies access and opens multiple pathways to prevention, testing, and care. Next slide. So a bit of the quintessence, actually, as you know, WHO is recommending HIV self-testing based on the evidence that were gathered through the work that we have conducted, and the evidence that we have for HIV self-testing is now very strong, which has contributed to the WHO recommendations. And lots of this work that contributed to the evidence was done by the STAR project. So HIV self-testing is now recommended by WHO and should be offered as an approach to HIV testing services and an alternative approach. It can be used to maintain essential services as an additional testing option in facilities and as part of PrEP and PEP delivery. We now have multiple quality assured HIV pre-qualified products. We have 7 products, oral fluid products, as well as blood-based products. And we have also very low cost options now, which further increases the cost effectiveness of HIV self-testing. HIV testing has also been shown to be safe, accurate, acceptable, and feasible during all the research that we conducted on this. Importantly, it also increases uptake amongst people who are often missed by conventional services, including men. They are missing in the first 95 and in the cascade and treatment cascade. Young people, key populations, first-time testers, and people who face stigma, distance, and time or confidentiality barriers to accessing testing services. So this evidence shows that HIV self-testing can be empowering and has not been associated with any social and clinical harms when implementation is happening and with appropriate support and referral pathways. We have also tested AI-enhanced digital technologies that are important for linking people into care and treatment, and for providing information on how to conduct the self-test so that self-testing is safer. So HIV self-testing is affordable, cost-effective, and can lead to substantial cost savings when adopted. Next slide. So very important now, I will be speaking a little bit more about the distribution modalities. There's a wide range of distribution modalities that can be adapted, and that is really important. Our strongest lesson from HIV self-testing is that the delivery models are mattering. And HIV self-testing is very flexible. It can be delivered through community-based campaigns, peer-led models, secondary distribution from people who receive the self-test for their partners, for example, partner distribution, social network distribution, and also can increase efficiency of facility-based self-testing through facility-based triage, workplace programs, pharmacies, private sector channels, and also through digital platforms where people actually can order their self-test in combination with also ordering their PrEP supply. So this flexibility makes it really very powerful. As I said before, HIV self-testing increases the access point where people can access it and increases equity of access. So different population needs different access points. Men may reach out to workplaces and community models. Key populations may prefer peer-led or community-trusted channels. And a lot of our investment went actually in community-led initiatives for self-test distribution. Facility clients can use self-testing to reduce waiting time, and that also obviously reduces the provider workload. The innovation is the ability to redesign HIV testing around people's lives and where people want to access testing services. In the following slides, I will be discussing a bit more the couple of evidence areas that have contributed to the global recommendations for HIV self-testing, including the service delivery models that were effective, as well as speaking about cost and cost effectiveness. Next slide, please. So the evidence from community-based self-testing, and here example from Zimbabwe and Malawi, we have evidence for this was generated in multiple countries, obviously, and a lot of pieces. I'm just showing you as an example. This was the early proof of concept for self-testing with community-based distribution. So we could show that during campaign periods where self-testing was intensified through community-based door-to-door distribution of self-test kits, we could increase testing uptake for testing for people who have not tested before between 42 and 50% in Zimbabwe and Malawi. In Malawi, door-to-door distribution was also associated with higher recent testing compared to areas without HIV self-testing, and that was done during a randomized control trial. It was after adjusting the relative factors in the analysis, door-to-door HIV self-testing distribution was associated with a 16.1% higher percentage of recent HIV testing compared to the comparison group. The slide also shows another important point. HIV self-testing can also support linkage into care. So in the HIV self-testing campaign areas, as compared to the areas where self-testing was not distributed, there was an increase in ERT initiation around the campaign period, and an increase in ERT uptake by 35% as compared to the control clinics. So this demonstrates that HIV self-testing contributes to case finding and treatment initiation when it's connected to clear referral and linkage systems. Next slide. Let's go now more into the costs and cost effectiveness of HIV self-testing is really, really important. This is a summary of the multiple costing and cost effectiveness studies that we conducted, and also based on a literature review of HIV testing modalities, including HIV self-testing. So HIV self-testing costs vary by model and context. For example, cost per kit distributed have ranged from about $7.9 to $14.8, depending on the distribution modality. More expensive for secondary distribution in South Africa, for example, and also in terms of community and workplace distribution, Eswatini, about $18.9 per test distributed. What we found in the coincidence of assessing all the costing models was HIV self-testing can achieve lower cost per person tested than standard testing, especially when uptake is high, linkage is strong, and programs operate also at scale. So there are economies of scale with HIV self-testing implementation in terms of cost reductions. Higher uptake, better targeting, strong linkage, and efficient distribution are the main drivers of cost effectiveness of HIV self-testing. Next slide. A little bit more about costing here. Facility-based HIV self-testing, which was not the focus initially of our interventions, but becoming more important now in the current funding environment. And as you probably have seen, WHO has provided recommendations potentially for using HIV self-testing as in replacement for the E1 test and in constrained, resource-constrained environments. Because it could reduce, the costs for HIV testing based at facility level. So low-cost HIV self-testing can help fill the human resource gaps by reducing at healthcare facilities by reducing the amount of healthcare worker time required for routine testing. So a lot of the cost for HIV testing at facility level is actually going into human resources. Yeah, this matters because healthcare worker time is one of the most constrained resources in the HIV program. The modeling that we're showing here show that routinely using HIV self-testing in facilities can generate savings, particularly when staff time is reduced. Even when considering scale-up costs for self-testing, overall cost can remain lower and staff time can fall substantially. This means HIV self-testing can help preserve services access while allowing healthcare workers to focus on clients who need clinical assessment, confirmative testing, ERT initiation, PrEP initiation, and more complex care, rather than spending their time on testing people, where self-testing can be introduced as a very efficient and effective way of increasing coverage at healthcare facilities for self-testing. Thank you. Next slide. Another very important aspect and use case for self-testing is now HIV self-testing has the power to transform HIV prevention. So HIV self-testing is an entry point and very critical for HIV prevention. Globally, we still have 1.3 million new infections annually, while in 2030 goal is that we want to reduce this to fewer than 335,000 new infections. We cannot reach that goal if HIV testing remains too difficult, too facility dependent, or disconnected from prevention options. So self-testing can simplify the prevention pathways. It can support PrEP initiation, PrEP continuation, PEP access, partner testing, and re-engagement, and becomes also even more important now as long-acting prevention options like injectable PrEP or long-acting oral PrEP with the introduction of MK8527 become available. These products will require testing models that are flexible, accessible, and scalable, including models that move beyond traditional clinic-based delivery. So self-testing can undo that bottleneck that we have as testing in access to prevention services, and especially in access to PrEP services. Next slide. One more example here, very important for scale-up, is the pharmacy-based HIV self-testing that can become game-changing. This is a model that describes, that shows, enables self-care that is particularly important for today's discussion. The model looked at broader community-based access to HIV self-test kits, PrEP, and ERT through pharmacies and community-based healthcare workers. The findings are very powerful. Enabled self-care is more than doubling testing coverage in this pharmacy-delivered model from 5% to 12.7% for adults tested every 3 months. It also reduces HIV-related deaths by 18% and HIV incidence by 27% over 10 years. And over a 50-year period, it was able to avert 34,000 deaths with reduced program cost by around $6 million, and was cost effective in 95% of modeling settings with the strongest value in higher prevalence context. So the savings come mainly largely from preventing advanced HIV disease, reducing expensive clinical care, and reaching people earlier with prevention and treatment through this pharmacy-based HIV self-testing model. Next slide. So based on, this is the made a quintessence and the summary point for my presentation. HIV self-testing is no longer innovation, but a necessity. And this is based on the editorial that summarized the evidence and call to action based on the evidence and roadmap generating by the STAR project. This is part of a publication. Next slide. So next slide, please. That summarizes this in the next slide. Can you move to the next slide? I cannot see it moving. So yes, so the lessons from the evidence is clear. HIV self-testing is no longer a novelty. It's no longer just an innovation. It's now a necessity. And today's constrained financial landscape, we need flexible, resilient, locally driven models. HIV self-testing can safeguard hard-won gains by expanding access, reducing pressure on facilities, supporting prevention, enabling people and communities to take a more active role in their health. The future is not HIV self-testing in isolation. The future is HIV self-testing linked to larger self-care agenda for HIV, linked to PrEP, PEP, ART, SRH, digital tools, community systems, and primary healthcare. And this is how self-care becomes part of a stronger, more sustainable public health system. So some closing and call to action is we need bold action to embed HIV self-testing into routine service delivery. Second, we need to streamline policies that allow HIV self-testing to support testing for PrEP, PEP, re-engagement, and broader prevention services. Third, we need stronger partnerships with communities, pharmacies, the private sector, and health delivery and health systems leaders. And fourth, we need better use of data and digital tools to support demand creation, linkage, follow-up, and continuation while protecting privacy, trust, and equity. And that includes HIV self-testing. So my final message is self-care is not a second best option. Self-testing shows that self-care can expand access, protect dignity, reduces pressure on health systems, and deliver strong value for money. Thank you very much. My next slide is just acknowledging the contributors to this